Well, good afternoon, everybody. Today we have our own Abdul Nuqali, who will be talking to us about donor heart selection. We all know Abdul very well, but just for those of us that don't know about his background a little bit. So Dr. Nuqali is originally from Saudi Arabia, and went to medical school at Qura University in Mecca. He then moved on to the States, where he did his internal medicine residency at George Washington University in Washington, D.C. Then he went out to the Midwest, did his general cardiology fellowship training at Kansas University Medical Center in Kansas City, Kansas. And after that period of time, then we were fortunate enough to have him join us here in New Haven, where he is now completing his fellowship in advanced heart failure and transplant cardiology. Dr. Nuqali is currently looking for a job for next year, so we'll wait to see which location will entice him next as he makes his way around the States. So today he's going to be talking about a topic that's very relevant to what we do on a weekly basis, and something that the fellows in training are supposed to have a very good understanding of prior to the time that they complete their training. So there was a paper that was recently published, and Dr. Nuqali is going to go through and discuss the characteristics or the information that was presented in that paper. So I'll not steal his thunder any further, and we'll just turn it over to Abdul. Thanks so much, Abdul, for taking the time to put it together, and look forward to hearing what you have to say.
Thank you, Dr. Beasley, for the nice introduction. And so it was very nice for me to go through this guideline. Just pull up here. So it was recently published in the Journal of Heart and Lung Transplantation back a couple months ago about the donor heart selection, evidence-based guidelines for providers. And this guideline was evidence-based and expert consensus recommendation for selection of donor heart following brain death, because most of the references they were used in these guidelines were prior to the DCD era, but a lot of it's still applicable. And it was consisted of international panel of experts based on extensive literature review. They did more than 400 references at the end of the study. And just go here over the classes and level of evidence for the International Society for Heart and Lung Transplantation. They have class 1, that is evidence or general agreement the treatment is beneficial. And they have class 2, which they have A and B. A, the weight of evidence in favor of the procedure or the test. 2B, the usefulness is less well established. And then class 3 is the treatment or the procedure is not useful, or and sometimes could be harmful. And then the level of evidence, we have level A, which is data from multiple randomized trial or meta-analysis. Level B, data from single randomized trial or large non-randomized studies. And level of evidence C is consensus based upon experts' opinion or small studies or registered data. And as we're gonna see in these guidelines, most of the stuff is level of evidence C, as well as most of the heart transplant literature. And before going into the guideline, I just wanna bring this slide to understand that it's usually not just about the donor risk factors, because most of this guideline is based on the donor risk factors, but we also have to weigh in the recipient risk factors: older age, congenital heart disease, pulmonary hypertension, prior sternotomies. And then we're going to take also the donor risk factors: older donors, LV dysfunction, LVH downtime. Then also we have to meet the recipient needs in terms of HLA compatibility, the ischemic time for sizing, gender mismatch. And beyond all of these, also we have the recipient urgency. If we have like very sick patient on multiple inotropes, VA, ECMO, every minute, every day matters. And at that time, sometimes we can compromise a little bit from the donor quality compared to a patient who is sitting at home waiting and stable. So at that time, we will have more scrutiny about the donor we're going to take. And the outlines of the guidelines, They talk initially about the clinical stability of the donor, and then they went on to the donor demographics, donor comorbidities, donor drug use, infections in the donor, malignancies in the donor, and then they went on diagnostic studies, the role of echo, MRI, cath, and then they talk a little bit about the rational use of extended criteria, and then they had a couple recommendations about international practices. So we're going to start here with the clinical stability of the donor. They give class 1 recommendation. Donor who is receiving low dose norepinephrine less than 0.1 milligram kilogram per minute may be considered. And as a general rule, the higher dose of norepinephrine, the poorer the expected outcomes after transplant. And they give level 2A if inotrope or vasopressor required to maintain adequate circulatory function. They recommended Swan gas catheter and goal-directed therapy for the donor. And these suggested hemodynamics for the donor, MAB more than 60, cardiac index more than 2.4, CVB less than 12, pulmonary capillary wedge pressure less than 12, and LV stroke work index more than 15. And this recommendation based on study from UK, I think was published in 2002, and they did Swan guided donor selection. And overall, there was no significant difference between the patient who had poor hemodynamics or good hemodynamics, but overall, these were the physiological numbers they used in that study. And then for the donor metabolism, they give class 2A for the patients who had moderately abnormal serum sodium, may be considered for transplantation. Patient who had extreme hypo or hypernatremia, serum sodium less than 129 or more than 170 should not be used. And donor hypoglycemia should not be contraindication for heart transplantation. And then they talked a little bit about the mechanisms of donor death, and they talked specifically about donor death by carbon monoxide poisoning, explosive brain death, and unexplained causes. And for this carbon monoxide poisoning, they give class 2 recommendation for donor with CO poisoning should be carefully screened. And the risk for early heart allograft dysfunction included ischemic ECG changes and elevated troponin more than 0.7 and LV dysfunction. And based on that, they give level 3 recommendation for donor with CO poisoning and carboxyhemoglobin level more than 40%, ischemic EKG changes, and elevated troponin level or ventricular dysfunction should generally not be used. And for the explosive brain death, usually may be considered for transplantation. There was some evidence of increased cardiac allograft vasculopathy. And for unexplained death, they should be carefully screened with EKG and when appropriate coronary angiogram. And they give examples for stuff to consider: hypertrophic cardiomyopathy, long QTC syndrome, Brugada syndrome, and congenital heart disease, including coronary anomalies. And donor with unexplained death can be considered after everything ruled out. And then for the donor demographics, regarding the donor age, they give class 1 level recommendation, the use of donor heart less than 45 years of age. And just a reminder, all these recommendations for DBD, donor after brain death. And for donor more than 45 years of age can be used after screening for significant coronary artery disease. And if short ischemic time less than 4 hours can be expected. And class 2 recommendation for donor selection, older donor usually can be used in older or highly sensitized recipient as they have smaller compatible donor pool. And for the donor size, they give class 1 recommendation that allocation of female donor to male recipient may be done safely, especially in recipient without pulmonary hypertension and when adequate donor recipient weight ratio and or predicted heart mass are ensured. And they give value of predicted heart mass within 20 to 30% of the recipient is considered acceptable. They give class 2 recommendation, class 2B recommendation due to the impact of RV dysfunction, of the donor allograft, pulmonary hypertension, in the intended recipient should taken into consideration when determining the degree of acceptable size and sex mismatch. And for anti-HLA compatibility, they give class 2A recommendation. All patients should be ascertained and compared against the donor HLA at least virtually prior to acceptance for the organ transplant. And then they also talked a little bit that there is no agreed upon standard HLA antibody can be crossed and which should be avoided. For the blood type, ABO blood group compatibility should be confirmed, this class 1 recommendation. And for the ischemic time, they also give class 1 recommendation for the target total organ ischemic time should be less than 4 hours to reduce the risk of PGD and early death. Class 2A recommendation, transplant for time exceeded 4 hours for donor less than 45 years. So we can still give some time if the patient is less than 45 years of age. And with older donor, it is specifically recommended to avoid long distance transportation or other factors like redo, sternotomy, bad explantation, which can cause prolonged operative times, which can result in more than 4 hours. And then they give also class 2A recommendation for ex vivo normothermic heart perfusion platforms like Transmedics can be used safely to decrease ischemic time for distance procurement. For donor comorbidities, initially they talked about the LVH and hypertension. Class 1 recommendation, LVH should be assessed by measuring thickness of intraventricular septum and posterior wall on echocardiography. Class 2A, LVH more than 13 millimeter may be considered, particularly with younger donor less than 40 years of age and shorter ischemic time. And for chronic hypertension in absence of LVH do not appear to impact post-transplant outcomes, though these patients could be considered for transplantation. And regarding the coronary artery disease, they give class 2A recommendation. Donor with mild luminal irregularities, mild coronary artery disease may be considered for heart transplantation. And coronary angiography should be considered in donor more than 45 years old, depending on geography and other risk factors. And the risk factors known for coronary artery disease, hypertension, diabetes, MEL6, obesity, hyperlipidemia, tobacco, and cocaine or methamphetamine use. And myocardial bridging is rarely contraindication to transplantation. And they give class 2B recommendation for donor with single visit coronary artery disease amenable to PCI or surgical therapy may be considered after balancing the risk of coronary artery disease progression and the urgency of the recipient. And donor with left main or 2 or 3 vessels coronary artery disease more than 50% are best avoided for transplantation. And here they give a schedule about regarding the coronary angiogram. So we have a couple of recommendations here, but I feel like the general sense for these recommendations around 40 to 50 years of age, more than that should get the coronary angiogram. And we have various cutoff here. We have the UNOS age more than 40 years for men and more than 45. We have some European guidelines a little bit on the older side. They give recommendation for more than 55 for both men and women to get coronary angiogram. And for diabetes, they give class 2A recommendation. Donor with diabetes and no other risk factor can be safely used. And they recommended coronary angiogram if they have longer term diabetes. And the recommendation after CPR, so they give class 2 recommendation. These patients can be used if they have normal LVEF and hemodynamics. And the duration of the CPR more than 30 minutes in both adult and pediatric donors do not negatively impact the post-transplant survival outcomes if echocardiography and hemodynamics are favorable, meaning LVEF more than 50% after resuscitation. And then they went on to talk about the drug use in the donors. And they give class 2 recommendation for tobacco, depending on the donor age, more than 45 years should get angiogram. And donor with alcohol use may be used if the echocardiography is normal. For other substances like cocaine, amphetamine, methamphetamine, for donor with the history of cocaine use can be considered if no significant LVH. And no donor with past or active cocaine use should have coronary angiogram when possible. And donor with prior amphetamine or methamphetamine may be utilized if LVH, there is no LVH and echocardiogram showing normal LVAF. And donor with toxicology positive for multiple substances may be utilized if LVEF is normal. So overall, the general sense I get from the drugs used, usually if echo is normal, you can proceed with the organ. For cocaine, they recommended coronary angiogram when possible. And then they went on to talk about the infections in the donor and transplantation of heart from bacteremic donor is feasible, and they recommended consultation with transplant ID for these donors to recommend the antibiotics duration for the recipient. And they talked more specifically about fungal and bacterial and viral. And the general sense here for fungal infection, usually active fungal infection is contraindicated. And here they give specifically Aspergillus, coccidomycosis, Cryptococcus, histoplasmosis. So all active diseases were class 3, as we see here in the schedule. And usually history of disease, it should not be contraindication. And then usually they recommended consultation with transplant ID. For hepatitis C generally safe. Hepatitis B should be limited to carefully selected patients with discussing immunization and prophylaxis. HIV seropositive patient can be transplanted to HIV seropositive recipient if consented recipient. And then for TB, can consider the organ. For history of disease, they said accept the organ. For active disease, consider taking the organ after consultation with transplant ID, and usually for both, should the recipient have INH for 3 to 6 months or 6 months of active disease. And then for patients with increased risk factors for infection, like in this schedule, they have the risk criteria: sex with person who don't have to have HIV, hepatitis B or hepatitis C infection, men who have sex with other men, sex in exchange for money. For all these patients may be selected for transplantation with the surveillance post-transplant for disease transmission. And then for the viruses, for COVID virus, active confirmed COVID virus, they said they should be limited to informed recipients, and patients should be ideally immunized. And for recovered COVID infection can be utilized. And then for most of the other viral infection, if it's active like West Nile virus, Zika virus, confirmed disease should not be utilized. Chagas disease is also class 3, should not be utilized. And then all the meningitis, viral, fungal, amoebic should be not utilized, except for bacterial meningitis. The patient was treated, it still could be utilized. And then they went on to talk about the malignancies in the donor, and they give class 2A recommendation for non-melanoma skin cancer and low-grade primary central nervous system can be considered, as these patients usually tend to have low risk of transmission. And class 2B recommendation here for patients with melanoma, choriocarcinoma, breast or colon adenocarcinoma, lymphoma, or leukemia should be high risk for transmission. And they give also here recommendation should be high level of suspicion for metastatic tumor if the donor has unexplained non-traumatic cerebral hemorrhage. So it should be raised concern about primary malignancy. And they give her a nice table. I'm not going to go over it about the risks for malignancy. And they have 4 categories here. They have no significant risk less than 0.1, and the low risk patients 0.1 to 1% transmission, intermediate risk, and then they have risk, the high risk here more than 10% transmission. And we see here like the malignant melanoma, breast, colon, choriocarcinoma, CNS tumor in that category. And these patients should not be utilized. And for the diagnostic studies, we have class 2B recommendation for coronary angiography for potential donor with significant increased troponin concentration based on the clinical context. And the troponin itself was not independent reason to decline donor, as well as the BNP also is not independent reason to decline donor. And regarding the cardiac imaging, give class 1A recommendation for echo and serial echo if the initial echo showed LV dysfunction, and CT angiography could be alternative modality to coronary angiogram. And they give class 2A recommendation for pharmacological stress echo to differentiate between coronary artery disease or subclinical cardiomyopathy and reversible LV dysfunction, as patients usually, if they have augmentation with the stress echo with dobutamine, they have better outcomes overall. And they give class 2 a recommendation to use myocardial strain echo to differentiate between ischemic and stent myocardium. They recommended the use of contrast affinity to better visualize the myocardium. And for MRI, they said it's a useful option, but availability and ease of performance limit its use. And then coronary angiogram, they give class 2B recommendation to screen patients with coronary angiogram more than 45 years, or those who have diabetes, tobacco, or illicit drugs used like cocaine, amphetamine, methamphetamine. And then they give recommendation about the use of donors who meeting extended criteria for recipients who are challenging to match highly sensitized patients, patient on temporary mechanical circulatory support, or VAD complications. Consideration of an extended criteria donor may be life-saving. And we have here some examples for the patient with extended criteria. So they have the patient with initially low LVEF, especially from young brain dead donors, should be aggressively pursued. And it's reasonable to consider heart with reduced but improved LVEF. So if they initially have reduced LVEF but then improved on subsequent study, they can be considered for transplantation. And we have here a list of criteria. So for LVEF less than 45%, they can pursue dobutamine stress echocardiogram. And if there is good ventricular wall motion augmentation, these hearts can be considered. For LVH more than 1.4 centimeter, usually poor outcome if concurrent donor age, if older donor, or ischemic time more than 4 hours. And donor recipient size mismatch. We have lower survival with patient with predicted heart mass index more than 10 and 15 mismatch. And then for the donor with coronary artery disease, usually they have a little bit slightly lower survival rate in one vessel disease and worse survival in multi-vessel disease as expected. And then for valvular heart abnormalities, they said some donor with valvular defects, mild to moderate mitral or tricuspid regurgitation, a pre-transplant surgical repair strategy may be considered appropriate for very severely ill patient and extremely high risk of death. And then regarding the donor with prior transplant, if they have prior non-cardiac solid organ transplant, still these patients, we can utilize the heart. And prior chest surgery, they give class 2 recommendation. We still donor with prior thoracic surgery may be utilized for heart transplantation with careful screening and preoperative review. And here's interesting recommendation about patients, donor on ECMO. So they give class 2 recommendation, donor with VV ECMO support may be utilized for heart transplantation. And they give class 2B recommendation for donor with VE ECMO support due to hemodynamic instability associated with brain death may be utilized for heart transplantation if the organ can be weaned off support. So I looked into this study, which was based on Taiwan. They had 5 patients who were declared brain dead, and then after that, they had hemodynamic instability. So these 5 patients over a span of 10 years or more, so they had total 5 patients. They were placed on VA ECMO, and then they utilized their organs, including heart and kidneys and livers. And overall, they did not have worse survival long term. So that, I think, was the base of this recommendation. And then they give recommendations regarding the domino transplantation, which is like in this picture. For the they will take the heart and leg as on block from the donor to give it to patient 1, and then they will take the heart to patient 2 from that heart and lung. In they will take that heart from patient 1, so they will give patient 1 the heart and the lung as an on block, and then they will take the heart from donor from patient 1 to patient 2. So the recommendation, these can be considered with careful consideration of recipient condition and informed consent of the recipient. And recommendation regarding the persistent left superior vena cava can be used successfully, and they recommended ligating the left persistent superior vena cava. And regarding the coronary anomalies, they give class 2 A recommendation about unexplained ischemia or regional wall motion abnormalities after transplantation should be promptly evaluated by angiography to rule out anomalous coronary arteries, and they give class recommendation. These donors with anomalous coronary arteries should not be utilized. And regarding the PFO, they give class 1 recommendation. All the patients should be screened routinely by visual examination, palpation of the heart, the donor heart, and the routine probe examination of the atrial septum. And all patients with the PFO should be securely closed at the time of the procurement. And then they had a couple of recommendations about international practices. They give class 1 education strategies can improve organ donation. And then neither opt-in or opt-out strategies for donation has demonstrated superiority in donor organ utilization, and both has to be part of a broader nationwide strategy. And then they advocated for prioritizing transplant candidates for those individuals who have agreed to be potential organ donors in other strategy proposed to promote organ donation. And they also recommended data sharing among various countries to improve all overall outcomes. And they give class 3 recommendation for financial incentive, stating that financial incentives to donors and their families, such as payment for cells, tissues, and organs, are discouraged because they likely take unfair advantage of the poorest and most vulnerable groups, undermine the altruistic donations, and lead to profiteering and human trafficking. And on this note, that's these were the guidelines. If you have any questions or comments.
All right, well, thanks, Abdul. While anybody out there might be thinking of any questions, I just have a quick one for you. I guess as you were going through the document, I guess what was the item that you found to be most striking, or that you learned that you didn't know before, or were most surprised to learn about after reading through everything that you had covered?
I feel like interesting for me that using the donor who required VA ECMO, which seemed for me like very interesting. These patients like super sick, but I think probably like after declared brain death, and if they have like catecholamine surge or became hemodynamically unstable, still can be utilized, especially if you have like very sick recipient. And I went to read that article, which is interesting. It seems like they still utilize these organ after they already declared them brain dead, and they use the VA ECMO, but it has to be like successfully weaned from ECMO. And then overall, I feel like the general theme for these guidelines were like older patients usually they should get coronary angiogram. Overall, bacteremic patient can be utilized, viral infection, especially like meningitis, fungal infections, where it should not be utilized. And then also malignancy. I feel like we don't think a lot about malignancies in the donors, but also there was like nice recommendations. Usually like they are younger patients, so we are less inclined to think about malignancies in these patients, but just I feel like it can come up.
Wonderful. Anybody have any questions for Abdul?
Hey Abdul, it's Nikhil. That was
Yeah,
awesome. Great review. I guess like it's interesting that I mean, just looking at these, because obviously they're, talking about like DVD donors. And I guess like, what are your thoughts with what you've seen with our program and, our donor selection, like, because especially like we're utilizing, and I know there was a line in there about, using organ perfusion systems, but we're routinely using that. So, I mean, do you think these are sort of not quite in line with practice, or I mean, how do you feel about that?
I feel like overall, most of the recommendations are still consistent. I feel like for the pulmonary hypertension, for example, oversizing, or the donor infections, drug use, malignancies, I feel like all these probably should be utilized in DCD, as we don't have that much difference. I feel like the age of the donor is going to be a big factor here. And overall sizing, I feel like probably like we have been using quite the same predicted heart mass in our patients population.
I also think just like comment wise, just for you, and I know that Michael had mentioned that like in the past, maybe fellows felt like they weren't quite getting as good education regarding donor selection. I think, it might be important that you kind of take some formal donor calls with us to understand what we're looking for. And also just two brief things that I've learned in my brief time here is that weren't mentioned in the guidelines, which I think are hard to put in guidelines, is one, to look for RV dysfunction. There's a lot of comments on LV dysfunction, but postoperative RV dysfunction, I think, tends to be a huge issue, and trying to assess it on a donor is really hard because, as you probably have noticed, the echocardiograms are generally not up to the same quality as we're used to seeing at Yale. And so it's really hard to assess. And, not all of them do have Swan-Ganz. Almost none of them have Swan-Ganz catheters to understand the hemodynamics. So I find that challenging and something that you really have to deal with. And the second point, I guess, is also not in the guidelines, but I think our surgical colleagues are super important to kind of collaborate on when we do donor selection. Some programs, the surgeons do it on their own. In some programs, the heart failure cardiologists do it, and then the surgeons just kind of go along. But I think their input is incredibly important because they have a lot of insights into what they're going to be encountering, and then their visual inspection of the organ is really important too. And I didn't really see much about that in the guidelines, but I think we really need to rely on our surgical colleagues to kind of tell us what they're seeing, because that can often sort of trump anything we kind of look at from our non-invasive side. Anyways, just my 2 cents.
Thank you very much, Nikhil. Yeah.
Thanks, Nikhil.
And I feel like, that's also like another point. I feel like we rarely see Swan-Ganz catheter for the donors, which could be very helpful to determine the cardiac output, especially if they have initially low LV dysfunction. And another point with the DCD, I don't think we can pursue coronary angiogram. I'm not sure if anybody correct me if I'm wrong. With the DCD donor, can we still pursue coronary angiogram in these patients?
I think that's ultimately going to be difficult, just because unless that would be part of the standard of care of that particular donor, even though they are slated to be, withdrawn in terms of, care, that'd be hard.
Thanks.
I don't mean to put Catherine on the spot, but I have a copy of Jack Heart Failure here, and she's a co-author on this paper that was published from our group talking about survival after heart transplantation from COVID positive donors. So I don't know, Catherine, did you have any comments about how that might be integrated? And Mark's saying the study was done at Duke, so maybe Mark's got some insight into it as well.
I don't think anything drastic, but I'd say it'll be interesting. I'll see what Mark said as well with moving forward, how the disease is progressing, and it was just a URI in some people. So I think we'll see how things evolve. It's I think a interesting potential, additional way to expand the donor pool. Sorry for all the background noise on 5.2, by the way.
Very good.
Oh, sorry. My comment was talking about domino transplantation. We did that at Duke a couple times. The COVID stuff, we took COVID positive donors at Duke all the time. The premise was that they weren't admitted for COVID. It was mostly just something that was sort of found in the background, and their cycle times were usually not suggestive of active infection, more just sort of an innocent bystander. And then just to sort of, piggyback on Nikhil's point about RV dysfunction, I think it's especially important when you start thinking about preservation strategy and in particular with DCD, right? Because when we use transmedics, we're arresting the heart twice. And that, I think, from talking to the surgeons, Patrick, some of the people that I worked with at Duke, that's really when, the RV is sort of most at risk for ischemic insult. And so that combined with, if a donor takes a little bit longer to progress than you might expect, you're really potentially, fixing for some RV dysfunction postoperatively because it's such a fickle ventricle. And so, I think that's what I have learned over the last year or so, is to pay particular attention to, especially when size is an issue, and in patients with pulmonary pressures that are not as low as we'd like them to be. I think you really have to be careful about postoperative RV dysfunction. So I would try to take like a 3 strikes you're out sort of thing, right? And even really less, like if you're undersizing an organ and it's going to be a DCD hard on transmedics, like you really don't want there to be too many, potential hits on the RV, right? Like size mismatch, RV dysfunction going in, some elevated pulmonary pressures, like you're just fixing for problems. So trying to minimize all of those factors is important.
Thank you. Thank you, Mark.
Well, thanks everybody for participating in the discussion. If there's any further comments for Abdul or questions, if not, Abdul, thanks for taking the time to put this together. I know giving you a lot to work on and you're juggling a lot of different things, but I hope you learned something, and thanks for teaching us about the new recommendations.
Thank you, everyone.